My name is Zia. I'm one of the A&E registrars at Oxford University Hospitals. So today we're going to talk about AKI, oliguria. Right, let's jump into the topic. Oops, okay. So yeah, so I'm going to begin with a definition of AKI. So actually there were many definitions for AKI, rifle criteria, AKIN, and KidGo. So, I mean, sorry, I'm saying it might be not saying it right, but I mean, just speaking in the department, we just say KidGo definition. So basically it's kidney disease improving global outcomes definition. So as you can see, there are 3 stages of AKI. So the first one would be if the creatinine is 1.5 to 1.9 times the baseline of the patient, or if there is an increase of 0.3 milligrams per deciliter. Or, I mean, if you can see as, with the urine output as well, if it's less than 0.5 ml per kg per hour for about 6 to 12 hours. So this would be stage 1. And then stage 2 would be almost creatinine 2 to almost 3 times than the baseline of the patient. And then urine output as well, decrease in urine output for more than 12 hours. And then stage 3 would be more than 3 times, or if the creatinine is more than 4 milligrams per deciliter. And also the urine output is significantly decreased, less than 0.3 mLs per kg per hour for more than 24 hours, or if there is no urine output at all for 12 hours. Oops, okay. And then a few other terms to know. Again, oliguria would be low urine output for several hours, or if it's less than 500 mils a day. And anuria is when there is less than 50 mils of urine output over 24 hours. So in ED, majority of the AKI cases would be due to volume depletion. And of course, you do see patients who have already existing chronic kidney disease, and then on top of that, they have AKIs as well, but majority would be due to volume depletion. So, and then here, I think it will be important to consider like what might be causing this. So, I mean, an easy way to segregate this would be pre-renal, renal, and post-renal causes that we're going to look into now. So as you can see, there are many causes, especially with pre-renal. You see hypovolemia, especially, patients come in A&E with diarrhea, vomitings, or any hemorrhage, or excessive use of diuretics and burns and so on. And then another important reason would be hypotension as well, especially due to sepsis or decreased cardiac output. Not often that you see renal artery stenosis, but it's important to keep in mind if there is any small vessel disease, especially considering any embolism or thrombosis, and then if it's especially elderly people, for thinking about dissection. And then renal causes, again, some problem with the kidney itself. So any tubular diseases, nephrotoxins, especially drugs and contrast, and any interstitial diseases of the kidney, glomerular diseases and small vessel diseases. Abdominal compartment syndrome, which is kind of rare, but just to keep in mind. And then hepatorenal or cardiorenal syndromes. And then post-renal, this again is something that we see more in ED as well. So, somebody coming with trauma, and then especially kidney injury, actual injury to the kidney itself. And then if there's any blood clots or calculis. And then any urethra or bladder problems, and then prostate problems as well. And catheter problems, so especially people who are already catheterized and then they might come in with like a blocked catheter. So this could be a post-renal cause, and then some tumors. Right. So again, I think this is just a nice schematic of the causes that we had, discussed earlier. Just briefing about pre-renal, renal, and then post-renal causes of AKI. So, I mean, when we are considering AKI and any problem with the kidney, especially thinking about renal, pre-renal, post-renal, like what investigations could be beneficial. So urinalysis, of course, is the first one that we're going to be doing, and then if especially, sorry. And urine culture sensitivity, especially if you have somebody with recurrent UTIs or elderly people. And then ECGs, of course, especially to see if there is any hyperkalemia going on, VBG or ABG to see the acid-base status. Again, full blood count, electrolytes, urea creatinine, and LFTs. Chest X-ray again to see if there is any fluid overload, and then X-ray KUB or CT KUB to see if there is any renal calculi that are there. And ultrasound and drug levels if indicated. So talking about ultrasound, I think ultrasound is, especially if done bedside, would be a better choice of investigation. But if it's not available, or if the expert is not available, then we're thinking about getting CTs. Right. Next. And then just a general overview of how we're going to manage. Again, the first one would be treating identifiable causes. If it's any pre-renal problem, especially if the patient is in shock or has had hemorrhage, then fluids and replacement of blood if hemorrhage, the patient could benefit, or you can prevent further AKI. And then if there's any intrinsic causes of the kidney, again, that depends on the cause of what exactly is causing it. And then coming to obstruction, again, if it is especially a prostate problem, that's obstructing the urinary outflow, then you're thinking about catheterizing the patient. And if that's not possible, then thinking about suprapubic aspiration or suprapubic catheterization. And if there is any obstruction, then you're thinking about removal of that. So let's say like a huge calculi that is obstructing the ureter or the pelvis of the kidney, then you might want to consider discussing with your urology or colleagues, and then thinking about removing that obstruction. And then if there are any nephrotoxic drugs the patient is taking, then we're thinking about stopping them. And then this bit, treating only severe hypokalemia. So basically, like when, I mean, the kidney function, when it is, decreased or not optimal, then potassium, I mean, the potassium is usually lost in the kidneys. I mean, kidney excretes that. And if the function is impaired, then the ability to excrete potassium could be impaired as well. And then you giving more potassium could potentially harm the patient and could lead to, for them to go into arrhythmia. So you have to be very cautious, especially in kidney injuries when you're giving additional potassium. So this line, I mean, if it is severe hypokalemia, then you treat it. Otherwise, you avoid potassium supplementations, and then always maintaining euvolemia. And what I mean by this is if somebody's has AKI, or especially who have chronic kidney disease, and on top of that they're having AKI. I mean, we know know that, I mean, they've not had urine output for quite some time. But again, you also have to, and especially if they have, become ill recently, and they might be losing volume. So, I mean, fluids with like insensible losses. And so you have to consider, keeping them adequately hydrated. Um, and I mean, of course, just maintaining the balance, not overloading them with fluid, but also not ignoring the fact um, that they might be, dehydrated despite their status. So maintaining euvolemia. And then if there is acidosis, then like you can use bicarbonate to treat that acidosis. And the one thing I've mentioned here is about post-obstructive diuresis. So many a times what happens is, like if the patient is obstructed for a very long time and they've not had urine output, and as soon as you put a catheter in, it just starts pouring, like lots and lots. That's because, like especially with the kidney injury, the reabsorption capacity of the kidney might be not very good, and then fluid just pours out. So you have to keep that in mind, especially. I mean, initially, like as a medical student, I used to be really happy. Once we put a catheter, oh my God, so there's so much fluid stuck in there, and then it just keeps coming and coming. So that's something that we should be worried about. So I think Hala asks, what is the level of potassium defined as severe? So now anything going above 5.5, I would say, or rather 6, like if it's going above 6. So the normal range would be 3.5 to 5, and until 5.5, it's still acceptable, but 6 is something that's not acceptable, I would say. Did I answer your question? Or hypokalemia. So severe hypokalemia, sorry, my bad. So severe hypokalemia, again, so anything less than 3.5. So if technically by definition it's 3.5 to 5 is our normal. So if it is going from 3.5 to 3, it will be mild hypokalemia. But if it's going below 3.5, then you're thinking about treating. And especially if it is like, really going below 2.5, then again, that I think would be considered as severe. Right. So so coming back to the post-obstructive diuresis. So again, it can result in significant volume loss. So just it's just like when we're kids, we do the siphon system. Just suck from the pipe and put it. Everything just goes into the other container. So it's my analogy is similar to that. So everything just goes out. So basically, if somebody's having more than 250 mils for more than 2 hours, then you're thinking about admission. And then basically what you do is you replace that fluid back into the body until the kidney function itself normalizes. Right. So that's about post-obstructive diuresis to keep in mind. Right. So the next one, next slide is renal replacement therapy or dialysis. So there's a very good mnemonic. I'm sure many of you might have come across this AEIOU. So this is a good mnemonic, AEIOU, to see when dialysis would be indicated. So we'll go one by one together. So acidosis, especially if it's severe acidosis, like we're talking about if pH is 7 and then it's not treatable. So you're giving sodium bicarbonate and it's still not improving. Then you're thinking about discussing with the renal team and then considering dialysis. And then, of course, thinking about causes of what might be causing this. And then, anuria as well. If somebody already has CKD, and then let's say they're not on dialysis currently, and then now they've come to you that they're not urinating at all, then you're thinking about dialysis, and also AKI on CKD as well. If there is absolute anuria for I think more than 12 hours, then you're thinking about dialysis. So mainly acidosis and then anuria. These are the two things to keep in mind. E is any electrolyte abnormalities, especially if they are hyper and then they are not responding to your initial treatments. Then you're thinking about dialysis. Again, talking about a quick question, talking about hyperkalemia. If somebody has hyperkalemia, what would be your initial treatment? Calcium gluconate, yeah. And then insulin as well, yeah. So basically, yeah, you give calcium gluconate to stabilize the cardiac membrane, and beta 2 agonist, yeah, exactly. So salbutamol nebulizations can help, and then insulin with dextrose. So this can help. So you've given the treatment, it's not coming down, it's still staying the same. Then you're thinking about dialysis for the patient, right? And then coming to ingestion, so lithium or salicylate, methanol, ethanol glycol, theophylline, and so on. Especially, to keep in mind would be the first two, I would say, lithium, because somebody who's already on lithium, sometimes they just miss dose or, forget about it and then just double their dose, or sometimes there's deliberate self-harm, they want to, just end their life and then, take a lot of it. And especially with lithium, given the low therapeutic index, if there is significant overdose, then you're thinking about dialysis. And then salicylate poisonings as well, because it's easily available in the supermarkets, and as an OTC that's available. People tend to take overdoses, or just to end life or something like that. Then definitely, if it's significantly increased, then you're thinking about that. Next would be any volume overload. If, again, it's not responding to your initial treatments. So somebody's come with volume overload, you've given them, furosemide, but still significant overload, then you're thinking about dialysis. And here I found a really good line here. So it's an overload with persistent hypoxia. So if somebody is an overload and then they're having hypoxia, which is not, and then again, not responding to initial treatments, then you're thinking about dialysis and removing that fluid overload. And then the last one would be any uremic encephalopathy or uremic pericarditis. Also, there are some, especially with hyponatremia as well. It's a consideration for dialysis as well. I mean, again, despite they correcting it with 3% normal saline, it's not getting corrected, and patient is having significant symptoms. Then you're thinking about dialysis. And a creatinine of more than 10 milligrams per deciliter, and then blood urea nitrogen of more than 100. Again, the last two, I would say, definitely it would be more in context of the patient, and also a discussion with the specialty teams of what they think, what should be done next. So that's why I've written the last one, discuss with senior or nephrology team, especially when considering dialysis. Right. Next, so this is a really nice slide that I found. I think it was a link that was shared by Natalie. This slide that I found on one of the critical care websites. So it again goes through a good approach, I would say. So this, they said, I mean, is a more of a vision to have, or things to think about. So it's not like an absolute rule, but it just makes it easy for us to understand. So if somebody's coming in with oliguria, and especially significant decrease in urine output, then the top thing to think about is there any obstruction? Um, and then now with the ultrasound available so easily, just put the ultrasound probe and then see if the bladder is swollen up, and if there is a lot of urine in there already. And then if that's the case, and then you can try to put a urinary catheter. Or if there is a urinary catheter already, you can either flush it or replace. Replacing a Foley's catheter is better practice, I would say. And then, considering if there is any considering CT scans or further investigations. Right, and then considering hemodynamic evaluation, so just to see if the patient is maintaining enough mean arterial pressure. So having a normal mean arterial pressure means that kidney is getting enough blood flow for it to generate enough urine and maintain its function. And then any medications, any nephrotoxic medications. And then echocardiography to see if the patient is in fluid overload, especially in because cardiorenal syndrome or hepatorenal syndromes. And then input output to see if they're maintaining adequate balance. And then if there is any history of fluid retention and need for chronic diuretics, and any evidence of low cardiac output, or evidence of septic shock and evidence of systemic congestion. So if you're suspecting hypovolemia, then a volume challenge. We'll talk about volume challenge in a bit. So giving them some fluids and then see if their urine output is increasing. If it is increasing, that's great. If not, then we're thinking about what are the causes of AKI. And then if you're suspecting, mean arterial pressure is inadequate, then we're thinking about vasopressors. Again, this would be after fluid. So first you give a little bit of fluid and then see how they're responding. And then still not responding, then you're thinking about vasopressor challenge. And if you know that, there's, cardiac problems, there's no adequate contractility of the heart, then you can consider inotrope challenge and then see if the urine output increases. And then the last one, if you're suspecting intrinsic renal failure or congestion, furosemide stress test. So this, I'm afraid, we do not routinely use in the emergency department. But I think, again, in the ICUs as well, having worked in the ICU, there's still a bit, not, a big fan of this stress test, I would say. But sometimes what doctors try to do is give a little bit of furosemide and then see if they have urine output. If they have, that's great. That means just need some more fluids. But again, I wouldn't stress too much on this one. So especially again, like coming back to what we had discussed in the second slide was, the most common presentations that we come across is, due to volume depletion, and then we're thinking about replacing that volume. Right. Sorry. So before we go, and then about the fluid challenge, and especially in heart failure patients. So, we as doctors, and especially in the new years of practice, or when we get down to the shop floor, we're a bit cautious about giving fluids. So I would say, especially in heart failure patients, give 250 mils, and then over 15 to 20 minutes, and then see if it's responding. Look at the blood pressure, if there is tachycardia, if it's settling down, and if it's giving response. And if you don't see any response, you can give another 250 mils and then reassess again. And then despite if there is no increase in blood pressure or increase in mean arterial pressure, and then you're thinking about any vasopressors or inotropes. If it's heart failure, you're thinking about inotropes first. Right. So let's discuss a few cases and then see how we go about. So this is a 70-year-old male who's presenting with inability to urinate from past 24 hours. He's had unintentional weight loss of 10 kilograms in the past 6 months. He has night sweats and generalized fatigue. So on examination, he's conscious, coherent, and then he's slightly distressed, I would say, and then he's appearing thin. His temperature is 37, blood pressure 160/90, heart rate of 102, respiratory rate of 22, and maintaining saturation on room air. On palpating his abdomen, you see there is a tender mass palpable in the suprapubic area. So yeah, just by looking at this, I mean, what are you thinking? Yeah. So these are the things that we're thinking. Yeah, it's possibility. Yeah. So all these things are a possibility. So especially palpating, I mean, this mass that you feel on the tummy. Given the history of weight loss, night sweats, I would be thinking about cancer as well. So okay, this came up. So what's the next step? So you're thinking about this gentleman has not urinated in the past 24 hours, and then you feel a suprapubic mass. So you're thinking about definitely an obstruction that is going on. So what you do is you catheterize the patient. It's likely, given the history, that it's likely there is definitely some prostate problem. Yeah. CT scan, PSA levels. Yeah, we'll definitely come to that. But right now we have a problem. We know that the bladder, is full. We need to empty it first. So the first thing we do is catheterize. And another way to do this one would be if you have an ultrasound, take a probe, just put it, and then you can see that the bladder is really swollen up. I mean, or enlarged, and then we need to get the urine out first. So sometimes it might be challenging, especially with prostate problems, to advance the catheter. So I mean, don't force the catheter. Try to catheterize. Don't force. But if at all difficult, you think about calling your senior urology team, and then they might consider suprapubic aspirations. Right, and then we're thinking about a direct rectal examination to see, the contour of the prostate that can confirm your suspicions about prostate problems. And then always, take a chaperone with you when you're doing a direct rectal examination. So basically, you've done a direct rectal examination, and then it showed a firm prostate, non-tender, and it's irregular. So again, the likely diagnosis at this point, I mean, you don't know if that's for sure, like a cancer or what kind of cancer, but it's what you're thinking in the background. So acute urinary retention due to carcinoma of prostate. And then how will you confirm the diagnosis? So again, taking detailed history of what's going on, and especially including his, what medications he's taking, and getting more history, I would say, and then a full physical exam, including rectal exam, urinalysis, electrolytes, renal functions, and then bedside ultrasound. Again, if you're thinking about if cancer is your top thing on your mind, then you're thinking about PSA levels. Right. Right. Talking about the second one. Oops, sorry. Okay. So it's a 50-year-old female who's presented with left-sided flank pain. It's dull and it's constant, not non-radiating, and then she's had this pain from past 2 days. So she's decreased urine output since yesterday, and she feels nauseous, um, pain and burning sensation while urinating since last week. Denies any abdominal pain um, or vaginal discharge. So basically, it's a flank pain. I mean, belly is okay. She took paracetamol ibuprofen last night, and when she woke up, she's still in pain. And also, she said she was feeling hot, and then she just wanted to come to ED. Um, right. So basically, she had burning sensation in urine for the past week, and then this new onset or like relatively new onset um, left-sided flank pain. So on examination, she's looking okay at the moment. So she's conscious, coherent, and obeying commands, and just looks lethargic. Her temperature is 38 degrees Celsius. Heart rate is 110, blood pressure 120/70, respiratory rate of 18, maintaining SATs on room air. There is left flank tenderness on palpation. Any additional questions we could ask to this lady? Okay, is there any hematuria? Uh, right? Yeah, menstrual cycle. Yeah. Any history of UTI, recurrent UTIs, or any kidney stone past? Yeah. So I mean, yeah, definitely we can ask her, and especially given her age and any chronic illnesses. Yeah, any comorbidities. Right. Right. So a lot of questions like we could ask in direction of this to to establish where this is going exactly. Right. Any weight loss? Yeah. Yeah. Right. So, so urinalysis. So you do urinalysis, and then it shows leukocytes of 2 plus, nitrites of 2 plus, and blood 1 plus, and then you've sent urine for culture sensitivity, and then when you get the white cells, there are 20, which is high. So normal would be around 9, and this is 20, and a creatinine of 120 micromoles per liter. Um, and a blood urea of 8. Ultrasound, so yeah, shows no renal calculi or no hydronephrosis. So at this point, what are you thinking? Pyelonephritis, UTI? Agree? Yeah. So this is a UTI. I mean, she's had history of UTI, and then now, it's just complicated by pyelonephritis, and then urosepsis exactly, because patient is, tachycardic and has temperature as well. And if you notice, I mean, she's had AKI as well. I mean, her creatinine was increased to more than 9, 10, 11, 12. So 30 micromoles per liter. Right. So talking about differentials, what could be some of our differentials? Cystitis, urethritis, vaginitis, right? So, I mean, there could be multiple. I've just written a few here. So this statement here. So in addition, I mean, patients who exhibit signs of systemic involvement, example, fever, should ibuprofen be stopped? I would, yeah, I would say we can ask her because, I mean, NSAIDs have a potential of causing or worsening renal function. So I think uh, we can ask her. I mean, there's no uh, solid rule that like absolutely contraindicated. We can ask her to take safer doses rather than uh, you know taking too many. Better to avoid, I would say. But yeah, I mean, if you think about, I mean, especially in renal calculi, The drug of choice is, diclofenac, 100 milligrams per rectum, which shows great results. So I would say, yeah, be cautious, especially if like if you know that is established CKD, then better to avoid. Right. So patients who exhibit signs of systemic involvement, especially fever, should be evaluated for other pathologies, including ectopic pregnancy or any perforated bowel or infected kidney stones, appendicitis, pancreatitis, colitis, and pneumonia. A good history and physical examination will help you narrow down these possibilities. So basically, what it's trying to say is if somebody's coming with systemic involvement, then think about other sources of infection as well that might be possible. Right. Oops, sorry. Right. So management for this lady would be antibiotics, especially broad spectrum antibiotics, hydration, analgesia, and antipyretics, and then exclusion of any other pathology. So my question is, should we catheterize this lady given that she has decreased urine output? Okay, right. So yeah, I would say, encourage her to take fluids, or, give IV fluids, or encourage oral fluids, and then see how she feels. I mean, she's not had anuria. She says she's had decreased urine output, but I mean, she's still weeing. So we should we catheterize? Okay, yeah, like I would say if she was in shock, if she was in septic shock, then I would be thinking about fluid balance and catheterizing her for sure. But let's say if she's if you stable and oriented, yeah, I agree. And then also this patient, I mean, I'll tell you more about this patient. Um, I mean, once we gave her some fluids, I mean, she improved. So that's why we're not thinking about this one. You can do urine output chart, of course. You can do while still in ED, or while she's admitted, without catheterizing. I mean, to see how much she had weed. You don't necessarily have to catheterize for a urine output chart. So I would say take it a step further. If she was shocked, then I would be definitely thinking about catheterizing her. So another thing to think about here is an uncomplicated patient versus complicated patient. So if it's an uncomplicated patient, does not have many comorbidities, is not pregnant, and is improving with your initial treatment, you can send them home. Although the presentation might have been, she is in sepsis, but still, considering the mental status of the patient, how just like an overall picture of the patient. Will this patient, so the question that I would be asking would be, will this patient that I'm going to discharge be able to manage at home? If you think, okay, she would be able to manage at home, and initially you see that with your treatment, initial treatment, she's getting better, then you can safety net her, saying that if things worsen, you can always come back and you can discharge her. But let's say somebody who's complicated, has a lot of comorbidities, and then let's say somebody who's has septic shock, or somebody who has not one source of infection, but maybe two sources of infection, urine infection plus pneumonia, then I would be thinking about admission. And pregnant patients, I would admit. Our patient, was admitted given her prolonged symptoms, and for AKI, for IV antibiotics. I might be mixing up. Sorry. So this patient, I mean, because she's had prolonged symptoms, although she was not in shock, she was, admitted by our medical team for. They thought they would give antibiotics. But there was a similar patient. I think it was a male who was okay. Like his fever and tachycardia settled down. He wanted to go home, and then we sent him home. UTI with this guy needs with AKI needs admission. Yeah, yeah. I mean, yeah. If there's, especially if there's significant AKI, you're right. Yeah, they would need admission. Yes, yes. For IV antibiotics. Yes. Okay. Right. So so the next one. Right. So this is a 70-year-old female. She's a known hypertensive, diabetic, and CKD. She was never dialyzed, and a history of recurrent UTIs. So she presented to ED with burning micturition from past 3 days, and then fever since yesterday, and has been feeling unwell today. And then she's not passed urine since, from the past 12 hours. Her baseline creatinine is 230, so where 45 to 90 is normal. So patient appears unwell, and then she has a temperature, it's high temperature, tachycardia, and then her blood pressure is 90/70. And a respiratory of 25, and then maintaining SATs on room air. So now, I mean, just with this picture, what are you thinking? Yep, AK on CKD, septic shock, yes. So, and then the possible source here, I mean, is urosepsis again, urosepsis causing septic shock. Yeah, yeah. Excellent. Okay, and then on examination, you see normal heart sounds. Air entry is clear bilaterally, soft abdomen, and then there's suprapubic tenderness. No neurology. Urine dip is positive for nitrites and leukocytes, proteins, blood, and glucose. And urine is sent for culture sensitivity. VBG has a normal pH, a blood glucose of 9, and a lactate of 3. White cells are 16, and a CRP of 130. And then blood cultures were taken right away. And a creatinine of 400 now. So her baseline creatinine was 230, and then now she has a creatinine of 400. So, I mean, thinking about the KidGo classification, what do you think? Is it stage 1, stage 2, stage 3? So let's say roughly, so now it's 200 was their baseline, and then now it's become 400. So it's almost increased more than slightly, I mean, about 2 times. Right. So this is, CKD on top of AKI on top of CKD, and then a urea of 9, and then normal electrolytes, and then you see a bladder scan. It's about 150 mils. So this lady is in shock. We've established, and then thinking about shock, it's septic shock, and then the cause for it is likely to be urosepsis, right? So with septic shock, urosepsis, AKI, and CKD, and then CKD likely because given that she's already diabetic. I mean, just thinking out loud, her CKD possibly could be diabetic nephropathy, and then which has led to shock. Right. So, and then thinking about management, again, you're thinking about blood cultures, urine cultures, so that we can give organism specific antibiotics. I mean, of course, on a later date, but I mean, as soon as you have the cultures, and then IV fluids, and then you're thinking about monitoring the blood pressure, heart rate, and urine output, broad spectrum antibiotics. And if there is no response to fluid challenge, then you're thinking about vasopressors here. Different EDs have different. I don't know how it's in Jerusalem, but I mean, like for example, when I had worked in India and in China, I mean, we would start vasopressors in ED. It would be ED decision, but here in Oxford, I see that. It will be more an ICU decision. I mean, of course, I mean, you consider about starting it, but here you discuss with ICU before you start any vasopressors. Catheterizing, of course, to again, as it was discussed in the chat, to monitor input output, and then how it's responding to fluid. And then especially be cautious. I would say be cautious with IV fluids in CKD, especially if they're oliguric or anuric. You don't want to overload them. Just give a little bit of fluid and then see how they're responding. Again, I think a similar style, I would say 250 mils, reassess, and then if needed, you can give 250 mils more. So this lady, responded well to IV fluids, and then was generating adequate urine output. Did not need to go on vasopressors. So she was admitted for IV antibiotics in our medical team, and nephrology opinion was taken. So they said, I mean, we'll wait and watch, and then see if the AKI improves, as with our initial treatment. So again, thinking about AEIOU, if the patient still has deteriorated, is anuric, is not urinating at all, despite your treatment, or IV fluid resuscitation, then you're thinking about dialysis. Right. So these are the last case for the evening. So it's a 30-year-old male. He's an IV drug user. And then he comes in with severe penile pain, swelling of his penis, and suprapubic pain. He mentions that about 20 hours ago, his partner placed a metal ring on the base of his penis. He was unable to remove the ring. I think he probably just slept, and then it didn't remove the ring. And then when he woke up in the morning, this was the scenario. So it's just woke up with severe pain, had not passed urine since all night. So on examination, you see that his temperature is 37, his tachycardic, blood pressure is acceptable, and then respiratory rate of 24. So now, I mean, looking at this condition, what are you most concerned about? Urethral obstruction. Yes. Necrosis, okay. Amazing, yeah. So as Khalil said, yeah, he needs catheterization first. Yes, definitely, excellent. So on examination, I mean, you see that his abdomen is soft. There is mild suprapubic tenderness with a distended bladder, which is palpable like a mass, but there is no rebounding or guarding. And then talking about genitourinary, so he has a 1.3 centimeter wide, 1.3 by 0.5 centimeter thick metallic ring present at the base of the patient's penis, located at the penile scrotal junction. The ring could not be removed in ED. So distal to this, penis was red, swollen, tense and tender on palpation. Sensations to the penile shaft and meatus were okay. So the circumference of the penis, was about 18 centimeters. Testes were okay, bilaterally descended, non-tender. So the first thing we're thinking about is giving him analgesia. The first thing is analgesia. So we had gained immediate IV access and then given him 10 milligrams of morphine. And then when we just, we knew, I mean, he had urinary obstruction for sure, but just, just putting a probe of the ultrasound, there's a lot of urine in there. Oops. So basically, yeah, think about the diagnosis. So basically, this is penile incarceration from a constricting metal ring. So now let's imagine yourself seeing this patient. You're not able to remove this one. I understand. I mean, you're thinking about catheterizing the patient and then giving him pain relief. But what would you do about the ring? Right. So yeah, thinking about, I mean, like, he might have to go to the theater to get it done. Right. It needs to be cut. Yeah. Right. So the first thing would be, give them analgesia, take the pain away from them. So let's say you've tried to catheterize and not possible. I think one of our colleagues said that suprapubic aspiration. Yes, you can do suprapubic aspiration or suprapubic catheterization to this patient. Right. So again, you might want to discuss it with urology before doing it. Right, and then removal of the ring in theater by surgeon. So I think usually urologists, would be able to do this. Right. So yeah, that's about any questions that you have. I think there was one question that I was not able to answer. What's the antibiotic choice that you said? Somebody had asked. Sorry, I might have missed the question, but I just have it on top of my mind. Like and Hatim asked, which antibiotics would you prefer? So I mean, usually we like in ED we have something called as micro guide, in our department, which basically tells us everything. So that's made by our our microbiology team. So basically giving broad spectrum antibiotics, I would say. And then on top of that, if you're adding gram-negative cover, let's say if you're giving some gentamicin, that'll be fine. And then once the cultures are back, you can give a organism-specific therapy to the patients. So we don't have to struggle to, to be honest, if you're in UK, you don't have to struggle too much with antibiotic choices. Everything is already decided. So if, let's say, sometimes what happens if the patient is allergic or, there is, you have difficulty in decision making about the antibiotics, you always have a microbiology registrar, so you can discuss with them and then do an antibiotic, appropriate antibiotic therapy. Otherwise, if you just give non-indicated antibiotic, you'll get an email. You'll get an email saying that why. Right. So, okay. So again, these are. It's not a stupid question, I would say. I mean, you have to know why to do it. So basically, it's to how do you say, to prevent or the venous drainage, and then to keep the prolonged erection. These kind of things are used by people. Yeah. Is gentamicin nephrotoxic? I Okay. I know aminoglycosides are could be nephrotoxic, but again, okay, I might have to look into this one. I think a single dose is not going to devastate the kidney, I would say. Let me put it this way. But it's a good question. I will also read more into it about this one. Sorry, I'm not able to accurately answer your question. Is it possible to see UCS positive and UA free? Can you Subi? Can you please tell me what's UCX? Is urine culture positive? Is that right? Urine cultures. Okay. Is it possible to see urine cultures that are positive, and urine analysis is? Oh, so okay. So please tell me if I'm getting this question right. So to see the urine cultures are positive, but urine analysis initially is negative. Is that right? Okay. Yeah, it's possible. Especially, I would say with elderly people, urinalysis gets tends not to be very accurate. But yeah, cultures are reliable. So like especially in elder people, I would have I would trust more their symptoms and urine cultures rather than a urine dip, I would say. So Khalil asks, should we use antibiotic? I think because the patient may have pyelonephritis. So is it the guy with the incarceration of penis? So the guy with the incarceration of penis, you can use it because I mean, there's again, there's no absolute indication at the moment that he's got pyelonephritis. But since, I mean, he's going to go to, you know, surgery, and especially if with, you know, really prolonged symptoms, if you are going to give prophylactically, you may consider. But again, usually we would, you know, wait, like, you know, for him to be symptomatic to give, I would say. It's possible, yeah. Urinary reflux can happen, yeah. It's a possibility, yeah. Okay. Right, super. You guys were a great crowd. Thank you very much for listening, and then your input was fantastic. Thank you very much.